Mr. Gish.
My lady, the next witness is Dr. Robin Howe. Could the witness please be affirmed or sworn?
Your right hand, please, and repeat the oath after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Thank you. Thanks.
Thank you.
Dr. Howe, thank you for coming to give evidence to the inquiry. May I ask you, please, when you're answering questions, just to keep your voice up and direct the answers towards my lady. Now, Dr. Howe, you have produced helpfully 2 witness statements for Module 7 of the inquiry. The first you'll see on screen is a corporate witness statement, and we can see in the first line 2 names, Dr. Giri Shankar and yourself, Dr. Robin Howe. That's because this statement is jointly signed by both of you, isn't that right?
Yes, correct.
And just to put things into context, you're both professional lead consultants for Public Health Wales during the pandemic. And Dr. Shankar was the professional lead consultant in health protection, and you were the professional lead consultant in microbiology.
Correct.
But as this is a corporate witness statement, not only have yourself and Dr. Shankar contributed to the statement, but where matters you've been asked about fall outside your or Dr. Shankar's personal knowledge or experience, is it right that you've sought input from others within the organisation?
Yes, correct.
If we could turn, please, to the last page, which is page 132 of the statement. And can you see at the top of that page, there's what's headed a statement of truth, attesting to the facts in the witness statement being true to the best of your knowledge or belief. Does that remain the case today?
Yes, that's correct.
And is it the case that although only you attend to give evidence today, you are able to speak to all matters in this statement?
Yes.
Thank you. And the second statement is a statement you've produced individually on behalf of yourself, dated the 2nd of May 2025, and that's on screen as well. And again at page 24, do we see a statement of truth which you've signed, attesting to the facts in the witness statement being true to the best of your knowledge and belief?
Yes, correct.
And again, does that remain the case today?
Yes.
Thank you. Now, both statements and their exhibits are with the inquiry, and the statements will be published. So please rest assured that the inquiry will be taking everything in those very full witness statements into account. But for today's purposes, if I may, I want to just focus on some specific topics and ask for further clarification or assistance with those as far as you're able. So let's start, please, with your professional background. You qualified in medicine in 1989, having trained in Cambridge and Newcastle upon Tyne, is that right?
Correct.
You then trained in microbiology at Sheffield and Bristol and became a consultant senior lecturer at Bristol University and North Bristol NHS Trust in 2002.
Correct.
2005, you moved to Cardiff to undertake the role of consultant microbiologist and head of the Welsh Antimicrobial and Resistance Programme for the National Health Protection Service, which was the predecessor to Public Health Wales.
Yes.
And your particular area of professional interest has always been, or has been, all aspects of antimicrobial resistance.
Yeah.
So following that interest, you were chair of the British Society for Antimicrobial Chemotherapy Standing Committee for Antimicrobial Susceptibility Testing since 2012.
Yes, correct.
And then from 2014, you were working within Public Health Wales as the National Clinical Lead for the Microbiology Division, which meant that you were providing overall clinical leadership for the Public Health Wales Microbiology Service.
Yes, that's correct.
And then in February 2020, you, alongside Dr. Giri Shankar, became an incident director for the Public Health Wales COVID response.
Yes.
And outside your role as incident director, your main role during the pandemic was focused on COVID testing. And you were the lead for the team delivering laboratory testing across Wales and also advising on operational and scientific matters. And then finally, in April 2022, you were appointed to the new role of Director of Infection Services in Public Health Wales. Is that correct?
Correct, yes.
So if we can just then go through a broad overview of Public Health Wales. It was established in 2009, wasn't it, as an independent NHS body in Wales. Is that correct?
Yes, correct. Yep.
And is it right that its overarching function is to provide professionally independent public health advice and services?
Yes, correct.
And one of those services is public health related specialist advice to the Welsh Government and its ministers.
Yes.
And in order to provide those services, there is within Public Health Wales a health protection division.
Correct. Yep.
And that encompasses within itself several teams, including, for example, the Communicable Disease Inclusion Health Programme and the All Wales Acute Response Team.
Yes, correct.
And as we've touched upon, so far as your role during the pandemic is concerned in relation to the inquiry and this module in particular, you provided advice in relation to test, trace and protect services in Wales.
Yes.
But importantly, you weren't the decision maker in relation to any test, trace or protect services. I use the word advice because you provided advice to the Welsh Government and they were the ultimate decision maker.
Yes, because Public Health Wales is part of the NHS and not part of Welsh Government.
Thank you. So that's an overview of your role. If we can move then on to one specific task which you had relatively early on during the period in which we're looking, which was the development of a health protection response plan. And just so we can see what it is, could we have up, please, INQ 56350, page 1, thank you. So is this the Public Health Protection Response Plan which you led the development of? And we see a publication date of 5th of May 2020.
Yes, that's correct.
And if we can turn to page 3 of that same document, please. Is an introduction, and going down the page we can see the heading, What Needs to Happen? And it says, the plan outlines 3 major activities for concerted public health action at scale. These are 1, preventing the spread of disease through contact tracing and case management. 2, population surveillance. And then over the page, please, 3, sampling and testing different people in Wales. So the language sounds relatively familiar to us now here at Module 7 of the inquiry, and is that because this public health protection plan formed the basis of test, trace and protect strategy
Yes.
in Wales?
Yes.
Now, we'll return to its contents a little later, but for now, could we take it off the screen, please? I just want to ask you a few questions first, if I may, about the development of that plan. You were instructed, I believe, to create the plan on the 22nd of April 2020.
Yes, that was when we had a formal instruction from the CMO Wales.
Thank you. And then on 4th of May, so I think less than 2 weeks later, you submitted a final version of that plan to the CMO.
Yes, correct.
Then the Welsh Government published its final test, trace and protect strategy on the 13th of May 2020, following, I believe, a 7 working day consultation with its stakeholders.
Yes, that's correct.
What I wanted to ask you about that time frame is this. With just under 2 weeks for the development of the plan, and then something like 11 days before the publication of the Welsh Government test, trace and protect strategy, do you consider that gave adequate time for the development of and consultation on the plan?
It was a very challenging timetable, although Public Health Wales had already been in discussion with colleagues in Welsh Government and also been doing some work in the background on thinking about, the TTP programme that would be required. But nevertheless, those, I think it was 10 working days, were very challenging, both to pull together the breadth of the document and then have some consultation. And in fact, the consultation that we were able to have with colleagues, stakeholders across Wales was really only 24 to 48 hours. But we did get helpful feedback that then that did play into the response plan.
Thank you. Now, we know, of course, you developed the plan, but the Welsh Government were responsible for delivery of the plan. During the development process, to what extent, if at all, was there any involvement of the Welsh Government in the development, or was it purely Public Health Wales developing the plan and handing it over effectively?
As I said, there was, at this point, a lot of informal discussion between colleagues in Public Health Wales and in Welsh Government. So it was not, there wasn't a formal working together on this, but informally we knew from what we had shared with them and vice versa, that this was, the direction was going to be appropriate.
Now, we mentioned, of course, that the plan, you were given the instruction by the CMO to develop it on the 22nd of April. Are you able to help us with why the 22nd of April, why there was no test, trace or protect strategy or plan before the 22nd of April, or even before the pandemic? I don't recall why particularly there was a question raised on the 22nd of April. Prior to that time, we had already started working on a TTP plan, and colleagues in health protection had drafted the outline plan a couple of weeks earlier than that. Prior to that and prior to the pandemic, the emergency response plans that we had worked through more usual health protection response levels and didn't take account of the extent of a pandemic response such as this. They had been appropriate for previous pandemics, such as the 2009 pandemic, but needed a different approach. I see, thank you. Now, we've touched upon the fact that you obviously your main role was to give guidance to the Welsh Government, and you helpfully mentioned that during the development of the plan there was some informal discussions. In relation to the guidance and advice that you provided to the Welsh Government, did it largely take the form of informal or formal discussions? How did you provide the advice?
At this point and during these, the development of the plans, they were informal discussions with colleagues within predominantly the CMO's office.
And generally speaking, when you would provide advice to the Welsh Government, what form would that take in the early stages of the pandemic?
Well, there were a lot of meetings, and I think you've heard previously in previous modules about meetings between colleagues in Public Health Wales, the CMO, and other colleagues in Welsh Government. And at lower levels in the organisation, people such as myself would be meeting with colleagues in the CMO's office.
And then I think, am I right that from about October 2020, you set up a system which you called the CMO Advice Notes?
Yes.
And what was that?
So prior to October 2020, there were a lot of informal and sometimes more formal interactions, but coming into Public Health Wales were a number of queries from different parts of Welsh Government and other organisations, and there was clearly a challenge in ensuring that the Public Health Wales response was collated in Public Health Wales and also directed into a single point in Welsh Government, because there was a danger of disparity in advice or where it landed in Welsh Government. So we set up the system of advice notes whereby the questions should come from CMO and the advice would be given to CMO.
Thank you. I'd like to just ask you, if I may, about instances when the guidance you provided to Welsh Government wasn't followed. First of all, paragraph 585 of your statement. Thank you. If we're looking at the second line and the bracketed line, you say, note, Public Health Wales had advocated contact tracing to commence on the basis of symptom onset rather than test result, but this was assessed as being not practicable. So is that one example of a time when you had provided guidance and it wasn't followed by the Welsh Government?
Yes, I think so. I mean, we felt that contact tracing on the basis of symptom onset meant that it could commence 2 days on average earlier rather than waiting for a positive test. That meant that contacts could be advised 2 days earlier to modify their actions, and that we felt it would have a bigger impact. There was a contrary issue that without a test result, it was possible that we would be contact tracing and isolating people who actually didn't have COVID but had symptoms due to something else. And so there was that concern about that system being more sensitive but less specific. And at this point in the pandemic, we were looking to come out of lockdown, and it was felt that putting a lot of people into contact isolation potentially when that wasn't justified was not the direction that we wanted to go.
Okay, now if we just turn to another piece of advice that you gave to the Welsh Government at INQ 56323, page 3, please. Thank you. You've said at the top here, the Public Health Wales IMT has discussed the changes from 14 days quarantine of contacts to 10 days. And then in the third paragraph, you explain that reducing the quarantine period from 14 days to 10 days will mean that an increased number of contacts will be mixing when they're infectious. And you finish by saying, however, we're concerned that the increased risk of COVID-19 transmission is a significantly greater risk for individuals who work with vulnerable people, specifically care home workers and healthcare workers. So were you there advocating for self-isolation for healthcare workers, especially to stay at 14 days rather than be reduced to 10 days?
Yes, for health and social care workers to continue contact isolation for 14 days.
Thank you. And then if we just turn to page 1 of that same document, please. And just going down to the email below, Robin, thank you. The CMO has responded to say we need to be careful not to divert from agreed Four Nations approach on this. If Public Health Wales have a different view, they should discuss with Public Health England colleagues. So again, is that another example of your guidance, there being pushback on your guidance, if I can put it that way?
Yes, I mean, there was an important principle of trying not to divert from agreed Four Nations approaches. And really, this was a situation where it was a risk balance. And we felt the risk was in favour of maintaining 14 days. There were a number of colleagues in England who had similar reservations, particularly in the world of infection control. And a paper following this exchange, a paper was put together by colleagues in England and taken to the senior clinicians group. That then led to an agreement that contacts would have reduced isolation to 10 days if they were healthcare or social care workers, but that residents and patients would maintain contact isolation for 14 days. And we accepted that view.
Thank you. We can take that off the screen. Thank you. Just want to understand, using those two documents as a touch point, how common was it for Welsh Government not to follow your advice? Can you think of any other key instances?
I can't recall other key instances. In general, Welsh Government followed our advice. There were, we were trying to, follow advice coming from the CMO group as well. Yeah.
Thank you. I just want to ask you just a couple of questions about your case management system. Because at the time the pandemic started, you operated using a case management system called Tarian, T-A-R-I-A-N.
Correct.
Which you'd had, I think, since 2017. Now, did there come a point around the time of the preparation of your report that you considered that Tarian was not fit for purpose for the Test, Trace and Protect scheme?
Yes, when we were mapping out the likely demand and workload within the system and predicting that, we could see that that Tarian would not be able to cope. It was server-based rather than cloud-based, and it was designed to be able to have a maximum of 500 concurrent users, and we mapped that we were going to need more like 3,000 concurrent users. So for those and other reasons, we felt we needed to develop a new system.
Was there a reason that Tarian was not tested or in advance of the pandemic, or at least in earlier 2020?
So Tarian was used up to the point at which we developed the CRM. So it was used in the first tranche of contact tracing that happened in February and March, but it had not been designed to fulfil what was required.
Thank you. Now, you mentioned in your answer about the contact trace, the self-isolation periods, about liaison with Public Health England, and I think that brings me to my next topic, which is I wanted to ask you about your work with the other nations, England, Scotland and Northern Ireland. One of the contributors, to place this in context, one of the contributors to the inquiry's Every Story Matters public engagement exercise said this: "I think you have to have a standard over the UK. You can't have something different in each UK country. When you live so close to a border, you could be working in England and living in Wales, or vice versa, and you've got two different guidelines." So, bearing that in mind, did Public Health, what was the extent to which Public Health Wales engaged with Public Health England and or either of the public health agencies in Scotland and Northern Ireland to try and aim for consistency?
So we very regularly engaged, initially on a less formal basis, but later on more formally with colleagues in England, Scotland and Northern Ireland. And there was an effort to try to keep key elements consistent between the four nations. But health is a devolved matter, and it is the responsibility of the Welsh Government and Public Health Wales as advisors to try and do the best for the Welsh population. So, we did take different approaches to our contact tracing, for example, but at the level of, trying to have the same guidance around 14 days or 10 days, we did try to work together.
You've said in your statement, we don't need to bring it up, but for your reference, it's paragraph 155, that Wales had limited ability to influence UK government decisions and that the largely porous border between England and Wales was pretty much impossible to close. Do you consider that there ought to have been greater account taken of Wales in decisions taken in UK government?
Well, I think it's an issue for the inquiry around the decision-making at UK-England level and how the four nations can be or should have been more closely involved in that decision-making, because there were clearly issues with central decisions made that then in Wales, that I can speak for, we then had to process those and assess whether they were appropriate for the Welsh population.
Thank you. Now, just moving even further outside the borders of the UK, you've mentioned, again, we don't need to bring it up, I think, but for your reference, it's paragraph 576 of your statement. You've referenced that in April 2020, following a request from the Chief Medical Officer for Wales, you established an International Horizon Scanning and Learning work stream. So a work stream looking specifically at international comparators. My question about that is this, prior to the pandemic, or indeed earlier on at the start of the pandemic, had Public Health Wales undertaken any exercises to learn from comparative international examples in relation to test, trace and protect?
So prior to the pandemic, Wales had, Public Health Wales had engaged with IAMPHI, the International Association of National Public Health Institutes, and in fact, was a full member of IAMPHI, and the purpose of that was to share public health knowledge and understanding. I'm not aware that TTP arrangements were discussed in that forum.
Thank you. Now, can move on then, please, to discuss testing. First, you may or may not have heard the evidence of Vaughan Gething last week, but he gave some evidence to the inquiry about the decision to stop community testing on the 17th of March 2020. He linked it to capacity, and he said, if you're going to have sustained community transmission and community testing is going to come back, you need a much bigger testing infrastructure. And so he said it was about scale up, the decision to stop community testing. And he said scale up didn't happen in the timeframe expected, and that was partly due to the issues with Roche. So I appreciate there's a bit to unpack there, but can I invite you, please, to comment on that evidence of Vaughan Gething?
Yeah, so at this point, we had moved into the delay phase of our response, and we were rapidly moving towards the first lockdown. People had already been enjoined to isolate if they had symptoms, so that actions were being taken in order to try and limit the spread. And with lockdown, the most draconian of actions to try and limit spread was going to happen in the next week or so. The issue of capacity was both an issue of testing capacity within the laboratories, but also sampling capacity in the community, in the health boards, and neither was in a position to be able to upscale at that point. And there was also an issue with capacity in terms of contact tracing. So if we had positive individuals, we didn't have the contact tracing system into place. So it was all of those three things that impacted what was available.
Thank you. Now, I actually do want to now move on to ask about asymptomatic testing, if I may. And it may be helpful to anchor that, or these questions, in the timeline of the Welsh Government's testing strategies throughout the pandemic. The first strategy, I believe, was developed in March 2020 and published in April 2020. Is it right that Public Health Wales had no formal input into that strategy, but did have informal input?
Correct.
And then 15th of July 2020 was a refreshed Welsh testing strategy. And is it right that at that point, whilst the main focus was still on testing of symptomatic individuals, there was acknowledgement that testing of asymptomatic individuals may be appropriate in certain settings, such as care homes?
Correct, yes. And in fact, a national framework for leading the NHS out of lockdown and into potentially more normal operations that Welsh Government published in 2020 also touched on asymptomatic testing in healthcare workers as well, and suggested that excess capacity could be deployed to routinely test asymptomatic healthcare workers.
Thank you. And then it may assist to look at INQ 227202, please. And page 1, thank you, is this is a written statement by the Welsh Government, and in fact more specifically by Mr Gething. And this was a statement, as you can see from the second paragraph, is it right to accompany the release of the Welsh testing strategy on the 15th of July?
Yes, sorry.
And then if we just turn to page 2 then. And if we look under the heading Testing in Care Homes, we can see 5 bullet points. We can see there all residents in care homes at the first bullet point were offered testing during May and June, whether they were symptomatic or asymptomatic. And then again, following the testing programme for all care home staff and residents, all staff in care homes have been tested on a weekly basis since 15th of June, whether they were symptomatic or asymptomatic. So do we see there a focus on asymptomatic testing as well? And so I just want to pause on that date of the 15th of July, and we can take that off the screen, thank you. Just to ask you about the advice you at Public Health Wales had given to the Welsh Government in relation to asymptomatic testing. So, first of all, when was it first appreciated by Public Health Wales that asymptomatic transmission was a possibility?
I think, and I speak personally, that I rather assumed that there would be asymptomatic infection and some level of asymptomatic transmission from the outset, from translation from other respiratory viral illnesses. It, however, became clearer during March, April, May that the extent of asymptomatic transmission. I should say that, asymptomatic transmission was a little bit difficult to define because it was defined to an extent due to the definition of symptoms. So that clearly there were, and others have touched on this, including Lord Valence, clearly there was a small proportion of people who were without any symptoms, but then a larger number of people who were palsy or oligosymptomatic, so had some symptoms but were not the typical symptoms, and that confusion made it slightly difficult to unpick some of the studies and the science as to exactly what was asymptomatic or palsy-symptomatic and how we should use that information to determine our testing policies.
Thank you. Did you give any guidance to the Welsh Government either for the March 2020 testing strategy document or for the July one in relation to asymptomatic testing, or indeed, as you say, palsy-symptomatic people?
So there was informal discussions around asymptomatic testing where we wanted to balance whether we would be better concentrating on testing or alteration of the symptomatology, because we could increase the number of healthcare workers who might be infected with COVID. We could increase the detection of them by either performing testing or by moderating the symptoms. So there was that was discussed. Yeah.
No, you just on that point, you've referred in your statement to having conversations with other countries, and in fact, am I right that you, for example, you just had conversations with contacts in South Korea and in Germany, and now just considering Germany in particular, could we please have up on the screen INQ 338265, page 1? Now, these are, it says TAC notes, so that's the Technical Advisory Committee, dated 15th of April 2020. Just first of all, briefly, what was the Technical Advisory Committee?
Well, so there was the Technical Advisory Committee or the Technical Advisory Group, and I'm not, sometimes their names were used interchangeably. I think this was the Technical Advisory Group, which fed into the TAC, which was the committee that was actually a Welsh Government internal group that took the information from the Technical Advisory Group.
That's helpful, thank you. So would Public Health Wales have been part of, do you think, this meeting?
So Public Health Wales, I think, were part of this discussion.
Thank you. So then if we turn, please, to page 3 of this document. If we look at the penultimate paragraph, about 4 lines from the bottom, thank you. And it's if you can see, there's a line that starts reconsidered with a question mark, about 4 lines from the bottom, and then
yes.
It's being highlighted now. Thank you. It says, TC suggested looking at the German approach, which consisted of daily testing of all healthcare staff, regardless of symptoms. So at this stage, 15th of April, it was known in the group that Germany was testing healthcare staff, regardless of whether they were asymptomatic or what their symptoms were. Was this something that would have come from your discussions with your German contact?
Yeah, so I wasn't part of the specific discussions with German colleagues, so I'm afraid I don't know exactly what was discussed with them.
Thank you. You've said that this is more likely the Technical Advisory Group, which involved Public Health Wales. Do you know whether this information was provided by way of advice to the Welsh Government in relation to asymptomatic testing?
I don't know, and I'm not sure whether Germany at this point, which was April 2020, was actually able to do daily testing of all healthcare staff, regardless of symptoms.
You're not sure whether Germany...
I'm not sure. I just don't know whether that was actually the case. That was quite early in the pandemic and would have required a huge resource in terms of testing.
Thank you. If we can take that off the screen, thank you. Now, just linked to that, the inquiry has heard, you may be aware, has heard in earlier modules about a so-called precautionary approach that could be taken in a pandemic. So, effectively, an approach to treat risks such as asymptomatic transmission as a possibility until they can be excluded. Now, keeping in mind what you've said about the fact that you always assumed asymptomatic transmission would be a possibility, and on the face of it, the fact that Germany seemed to be implementing asymptomatic testing, did you consider that the Welsh Government were taking a precautionary approach or not?
I think they were taking a precautionary approach within the resources that were available at that time. So, in order to test all healthcare staff with the PCR test, the simple testing process takes some time, but the sampling process would have taken a very significant amount of staff resource, which would have been a challenge for the healthcare institutions, which were really stretched in delivering other elements of the pandemic response.
Thank you. That answers my question, I think. If we can move on then from asymptomatic testing to the range of symptoms, and I'd just like to to read out an extract from a witness statement from Anna Louise Marsh-Rees of COVID Bereaved Families for Justice Cymru. It's paragraph 36, page 13. I think you've seen the statement.
Yeah.
Thank you. And she says, CBFJ Cymru are aware that testing criteria in Wales was limited to 3 cardinal symptoms, fever, cough and anosmia. The families and friends of many of our members experienced a range of symptoms outside these 3 symptoms, such as headache, sore throat, fatigue, nausea and diarrhoea, amongst others. And she goes on to say, the Welsh Government's failure to acknowledge this broader range of symptoms in testing criteria, even as late as March 2021, would have led to a very high number of instances of symptomatic people continuing to spread the virus. Now, just pausing there and moving on to another document that's linked to it. If we can have up on screen, please, INQ 116616. First of all, page 1, to place the document in context. This is ministerial advice dated 23rd of March 2021 for decision by the Minister for Health and Social Services. And if we can please turn to page 11, which might be a page that you recognise. Apologies, I think page 12 is the... Oh, no, sorry, it's back to page 11, my fault there. If we see at the top, there's a title, Expanded Criteria for COVID Testing, and it says author, your name, Robin Howe.
Yep.
And the date is the 15th of March. So this is advice from you that's included in that ministerial advice.
Yeah.
If we can turn to page 12 then, please. And in the bottom half of that page, we see a line starting, if symptom criteria are broadened, there are a few issues to resolve. And you talk about issues to resolve in relation to broadening the spectrum of symptoms. And then over to page 13, please. Recommendations, we see. It is recommended that symptom criteria for public access to testing should be broadened to include new and unexplained sore throat, runny nose, sputum production, fatigue, and to go on to list a number of symptoms. So do you recognise this advice as being from yourself?
Yes, yes.
And then if we please go back to page 1 of this document. We see again a heading recommendation. And can you see there that it says the Minister is asked to agree that all LHBs can recommend, local health boards can recommend testing for a wider range of symptoms, but that our national messaging should remain focused on the 3 primary symptoms until there's 4-nation agreement on widening the case definition. So just a few questions arising from all of that information. First of all, can you help us at all? You may not be able to, and if you can't, please say, but can you help us with why the advice was to persist with national messaging based on 3 symptoms?
So I think this was written at a time where, we understood that there was a wider range of symptoms for people with COVID, and that if we wanted to optimise the pickup of cases, that we should widen the definition. And a number of health boards had already started, because we were embedded with the health boards, they had already started to do this locally. And so we brought this to Welsh Government colleagues to reach a more standardised national approach. And as you can see from the ministerial advice note, there was agreement with broadening the symptomatology for testing, but a wish, going back to our earlier discussion, to await a 4 nations agreement on this before pushing that at the national level.
Did you or do you now have concerns that the delay, perhaps I should say, to expand the range of symptoms in public messaging could have resulted in individuals who did suffer from COVID-19 not taking a test because they didn't realise that they had COVID-19.
It's possible, yes.
Thank you. Now, we'll move on, if we can, to tracing, please. I wanted to ask you a few questions about contact tracing. And firstly, about the digital element of contact tracing. Is it right, first of all, that in relation to contact tracing, much as with the rest of the Test, Trace and Protect scheme, you sought to align with Public Health England in your approach?
We did as much as possible, yes.
Now, one specific question that has arisen time and again, which you may well be able to help us with, is in relation to the Welsh adoption of the NHS England app, or NHSX app. We know that Wales, unlike Scotland and Northern Ireland, did adopt the English app in late 2020. Now, first of all, did you have any concerns in Public Health Wales about adopting the English app?
Well, I think from fairly early on, we felt that the app was going to be an adjunct rather than a major part of our response. Our model for contact tracing was personal, someone speaking to another person, delivered by local teams who understood the local geography and culture. As the NHS app was being developed, there were concerns about, it needed Welsh translation and basic Welshifying, but also that it didn't follow it didn't follow exactly the same contact tracing guidance that we had. So we always recommended contact isolation, whereas there were some categories in England from the NHS app where people would be just asked to perform strict social distancing rather than isolation. So we had that concern, and then we were concerned that the data from the NHS app didn't then come into our contact tracing system. So the individuals would get some advice, but they weren't within our system, either for us to just know about them from the surveillance perspective, but also from the perspective of the support that we would wish to give them.
Thank you. Given those concerns, why did Wales or the Welsh Government ultimately decide to adopt the app?
I think it was really just because we thought that, for certain sections of the community, it may be a helpful adjunct, but, not a main plank of the response.
Now you've mentioned that contact tracing in Wales was delivered by local teams, and that's something I think that, in fact, if we can put up the plan again, your initial plan, INQ 56350, at page 3. And underneath what needs to happen, we can see under the contact tracing heading, contact tracing identifies individuals who've come into contact with an individual with COVID-19. You go on to say the plan proposes a 3-tiered approach across Wales at a national, regional and local level. It will require very large numbers of people to be involved as local contact tracing teams. They'll be managed locally and coordinated regionally. And that local authorities, health boards and other partners will be pivotal in leading and supporting local action. Now, it's right that, as we've heard from other witnesses as well, this differed from the approach in England. Now, why was it? Why was it that Wales decided to choose a local contact tracing system?
Well, we felt that there was a clear advantage in having a local system where people would understand the geography, and the culture within their local areas, and it was really growing out of the pre-existing arrangements. We had always worked very closely in terms of communicable disease management in the community with our local authorities, and they were very keen to be involved. And so something that was based on the local authority level, supported by our health boards, seemed to be the best solution.
Thank you. We can take that document off screen. Thank you. In terms of effectively feedback, if I can say that way, or monitoring of how local health boards implemented tracing, is it right that they produced operational plans for Public Health Wales? And is it right that the lead strategic director and his deputy reviewed the plans in August 2020 and concluded that they didn't provide complete assurance of a whole of Wales systems response for the next phase of the pandemic at that time?
Yes, that's correct, and feedback was given and then acted upon. Yeah.
And when you say acted upon, how were the problems addressed?
So the challenges in the 7 different responses were different. One was giving more of a sit-rep of what the situation was and wasn't forward-looking. And then others had various gaps, and all those elements were fed back to the health boards, who were the regional unit, for them to address.
And were the problems addressed as far as you're aware?
Yes, yes.
And now just finally on tracing, I just want to ask you a question about backwards contact tracing. Because am I right that in October 2020 you provided advice to the Welsh Government's Test Trace Protect programme board, which advised on the use of backwards contact tracing?
Yes.
And am I also right that the advice was effectively that full backward contact tracing was the best way to maximise the potential for effective contact tracing?
Yes, yeah.
Do you recall what the response was to this advice?
We put forward the advice around backward contact tracing because at that time, only 10% of cases had been identified as a contact already. So we were aware that there was a lot of transmission going on that we were not picking up. We were also aware that for most cases actually led to less than one secondary case, but a few cases led to many secondary cases. And it was felt that those were driving the community spread, so-called super spreader events. And so backward contact tracing is going further back, as the name suggests, to try and identify the source of infection, and with a view to being able to identify the super spreader events and try and get on top of those. Unfortunately, that requires very significantly more resource because it identifies many more contacts. And I think the outcome was that backward contact tracing was felt not possible as a blanket approach, but was definitely used in areas of high prevalence or to investigate particular situations.
So it was implemented, but only in specific situations. Yeah. Thank you. Now then, if I can just move on to, so you may have gathered, isolation and your role in relation to isolation. Now, am I right that Public Health Wales advised on numerous occasions about changes to self-isolation periods?
Yes. Yeah.
And I think you say in your statement, but we don't need to bring it up unless it would particularly help you. On the 10th of December 2020, the 31st of December 2021 and the 28th of January 2022, those were 3 changes to self-isolation periods. Now, is it right that you didn't provide any specific advice on the first change in December 2020?
I don't recall such, no.
You did provide advice on the 31st of December 2021
Yep.
in relation to allowing individuals to be released from isolation after day 7 if they had a negative test. And you provided advice again in relation to the third change. Now, did you all also undertake, I believe, or commissioned research in relation to the impact of isolation?
Yes, yes.
And if we can please get up on the screen INQ 56337. Is this an example of some research that was commissioned on the 10th of March 2021?
Yes.
And if we can turn then please to page 4 of that same document. And the third heading down, challenges of self-isolation. And the third bullet point, we see there the top 5 challenges contacts thought they would face during self-isolation were suffering from anxiety or mental health problems, looking after children, being concerned about the impact isolation will have on work or business, experiencing financial problems, and caring for vulnerable people who can't stay with friends or family. And then if we could then please go to page 6. Thank you. And under the bottom heading 1.4.2, we see developing and targeting support for those experiencing challenges while self-isolating. And there's if I can call it a recommendation, providing mental well-being and social support. Then over the page to page 7, please. We see 3 more recommendations in light blue. Sorry, just the second paragraph there. And the second paragraph is increasing financial support and access to food and medications for those with precarious incomes. So does it follow from this document that it was within, first of all, it was within your remit to advise on the impact of self-isolation?
Yes.
Does it then also follow that it was within your remit to advise on the necessity for, or indeed consequences of, support for those isolating?
I think throughout we were highlighting the issues and stresses the self-isolation caused for different groups, and giving a range of options to be able to mitigate some of those, to be able to make it easier for people to isolate. So within that comes a suggestion that increased financial support would help.
Now, we know, in fact, that the Welsh Government did offer financial payments for those isolating, initially £500, and then it was increased to £750. Given in particular your recommendations and your findings in relation to people's concerns about their finances when isolating, were you asked to provide any specific advice as to the financial packages or support offered by the Welsh Government?
I'm not aware of whether we had a specific query about, how much it should be or whatever like that.
Would you consider that you ought to have been involved in those discussions?
I'm not sure that we should. I'm not sure that I can answer that question.
Thank you. Then if we move on then to my final small topic before we get on to lessons learned and recommendations. Just want to ask you about equalities and inequalities. What steps, if any, did Public Health Wales take to ensure that test, trace and protect, and indeed isolation support, was effective in relation to protected groups or those with vulnerable characteristics?
So, as we noted with one of our studies, we did a number of studies that looked at the impact of various parts of the pandemic on different groups, including Black, Asian, minority, ethnic, and people in lower socioeconomic groups, etc. And all of this was fed into the TTP programme in terms of to the local teams as well as to Welsh Government to try to make improvements as to how they operated and could reach all the different different sections of the community.
And did you get any feedback from the local groups as to steps they'd taken, or was your role done at that stage?
I think we did get feedback, but I don't have that.
Thank you. Then just finally, if I can turn please to lessons learned and recommendations. You've very helpfully provided us in both of your witness statements with a list of recommendations and lessons that you've taken from the pandemic and your experience. The inquiry has those, and we will be taking those into account and using them going forward. Having had some time to reflect since those witness statements, is there anything that you wish to add today?
I don't think there's anything that I want to add to the what's written down in the two statements. Thank you.
Thank you.
Is there anything particularly you wish to highlight?
I'm not sure to what extent it is documented explicitly, but I would highlight the need for digital interoperability in the future, and also, as we have touched on this afternoon, the involvement in the 4 nations in UK decision making as well.
And when you say digital interoperability, between which different systems are we talking about? Systems around the UK or systems within Wales? All of them.
All of them, but specifically systems around the UK.
Thank you, my lady. Those are my questions. I understand that there are some questions from others.
Thank you, Ms. Nagish. Yes, I think Ms. Parsons, who's, if you look that way, they are. You've probably got direct sight.
Thank you very much, my lady. Good afternoon, Dr. Howe. I ask questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. My questions are about delays in testing of healthcare workers, care workers and patients. That's the overall topic. Firstly, in relation to testing of care home residents and care home staff in Wales, Mr Drakeford recognised in the Senedd as early as the 3rd of March 2020 that older people, especially those in care homes, were particularly vulnerable to COVID-19. That view that routine testing in care homes may therefore need to be prioritised was held by experts, and indeed it was a view highlighted in a paper produced by the Welsh Government Office for Science on the 29th of April 2020. On that date, the 29th, Mr Drakeford said this in the Senedd: "The reason we don't offer tests to everybody in care homes, symptomatic and asymptomatic, is because the clinical evidence tells us there is no value in doing so, and that such testing would divert capacity." He made a similar statement the following week, the 6th of May. Firstly, Dr. Howe, what is your view from a clinical perspective on Mr Drakeford's statement in the Senedd that there was no clinical value in asymptomatic testing in care homes?
So I think what he said at the end of the sentence was in care homes where there's no evidence of COVID. And I think that this was in a situation that the majority of patients would have had symptoms, and if there were no symptoms within the care home, it was felt that the likelihood, given the prevalence within the community, was very much that there would be no benefit from asymptomatic testing when there was no signs of symptoms.
So it's confined then to if there is no symptoms in the care homes?
Yes, I think that the expectation, I think, was at that point that COVID being present within a care home would be identified through the presence of symptoms.
Right, but what was your view from a clinical perspective on that statement, that there was no value?
I think there would have been limited value at that point for testing if there was no signs of infection within that care home. And it was around this time that there was whole home testing, including asymptomatic individuals, if there was signs of COVID within the care home. But if there wasn't any sign, routine testing of all residents and staff was not being performed. That started, the routine staff testing started on the 15th of June.
I won't dwell on this point for much longer because we have other points to cover, Dr. Howe. But as to the chronology of routine testing for care workers in Wales, asymptomatic testing or routine testing was announced on the 16th of May, as I'm sure you know, implemented on a weekly basis on the 15th of June, and then on the 4th of December 2020, twice weekly routine testing. And given what we know about the particular vulnerability of people in care homes, do you think it should have been introduced earlier and more regularly?
At the time, there were challenges in terms of capacity, not just testing capacity, but also sampling capacity and the ability to deal with the results appropriately. If all those systems had been in place, then there would potentially have been benefit in testing earlier. Most benefit significantly earlier during the earlier in the first wave, lesser benefit as the community levels of COVID were falling. We referenced the routine testing that was done from the 15th of June. In the week of the 22nd of June, 9,700 asymptomatic staff were tested through the Lighthouse labs, and of those 9,700, only 4 were positive. And from a purely statistical perspective, you would expect, with the specificity of the test, if you tested 10,000 individuals, that you would get around about 4 false positives. And so statistically, it was possible at that point that those 4 people who were identified were actually false positives. And this is just to give an idea of the fact that at a low prevalence, the number of cases to be picked up was relatively modest. But
Dr. Howe, I apologise for cutting in, but I've got other topics that I've been permitted to ask you about. That was June, the example you give, and obviously as we go further in 2020, we get to wave 2 and a much greater prevalence of the virus. I'm going to ask you now, please, about delays to routine testing of healthcare workers, which you have touched upon already in your evidence, and it was recognised very early on that asymptomatic testing was of benefit, and the inquiry heard evidence last week from experts that by 2020, April 2020, it was clear that asymptomatic testing of healthcare workers was absolutely essential. And you've referenced healthcare testing in Germany in April 2020. The chronology, as we understand it, is this. 4th of December 2020, the Welsh Government announced routine testing of healthcare workers. Implementation begins on the 14th of December 2020, and in many cases, Dr. Howe, it isn't in fact implemented until March 2021. Now, given what we know about the value of testing healthcare workers, in particular in relation to preventing nosocomial infection, do you think routine of testing of healthcare workers should have been introduced sooner?
So I think that the big change that happened in November was the availability of lateral flow tests. And that meant that the testing could be delivered at much greater volume and much more effectively in November. And we were able to take advantage of that and introduce the healthcare worker testing.
So you don't think it should have been introduced sooner?
If
or you do?
If we had the resource, and particularly lateral flow tests, that could effectively test for whether people were infectious, then I think there would have been benefit in testing earlier.
I want to ask you about resourcing and testing capacity in particular, please, because in the evidence that the inquiry has, and indeed in your statement, you talk about Wales's underutilising of its testing capacity. I'll give you two quick examples before turning to the question. 6th of May 2020, utilisation of 35% Public Health Wales laboratories, and January 2021, 24% of capacity. So does that not suggest, Dr. Howe, that actually there was a huge amount of capacity that was underutilised, and indeed testing could have been brought about or introduced much sooner?
So this was purely testing capacity that I was talking about and you've referenced, and that doesn't necessarily reflect sampling capacity or the capacity across the whole system to be able to support not only the sampling but dealing with the results. So there was not the capacity across the board to deal with what would have been a very significant increase in resource requirement. So if we were to have, using PCR tests, introduced healthcare worker testing for 80,000 healthcare workers, just the processing prior to the laboratory would have required something like 160 whole-time equivalent weeks of resource behind it. Not, that's in the pandemic, that might have been possible, but that was sampling was being at the responsibility of the health boards.
Dr. Howe, just before we move on to the last topic, I think the answer to my question is you don't think there was the scope or the capacity to test routinely sooner, but did you in fact advise the Welsh Government to do so?
I don't recall formal advice to test healthcare workers, although we were involved in the advice that I referenced earlier in June 2020 to use excess capacity to test asymptomatic healthcare workers. And the health boards responded to the extent that we were in July testing 400 healthcare workers a week, and that increased up to 2,000 a week in October 2020. And they were focusing on areas either where there were outbreaks or areas where staff were looking after particularly vulnerable patients, such as bone marrow transplant units, etc.
Thank you, Dr. Howe. And so I think the answer is that you provided advice, informal advice. I mean, you used the word in your evidence, informal discussion about asymptomatic testing. Is that correct?
Yes.
And was it advised to not test asymptomatically?
I don't think we advised to not test asymptomatically. We did raise the question of, why would we be testing and what was the best way of achieving the necessary outcomes from testing.
Thank you, my lady. I'm very conscious of the time. May I touch briefly on the final topic and I'll
Can you
be
shorten
quick?
it? Yeah, if you can shorten it.
Yes, I will. I'll shorten it, my lady. Thank you. I'm most
Thank you.
grateful. The last topic, Dr. Howe, is routine testing of patients in hospitals. And we know from an Audit Wales report in March 2021 that that needed to be strengthened further. Once tested on admission, I quote, "There has been no regular testing during a patient's hospital stay unless patients have developed symptoms." And then the report concludes that more should be done, for more effective testing should be done, including more frequent testing during a patient's hospital stay. And I think a Public Health Wales report of the 23rd of September 2020 said that there is evidence to suggest transfer of patients between wards and hospitals resulted in spread of COVID-19 to new areas in the hospital. Just quickly then, please, Dr. Howe, the question is this. Given the high levels of nosocomial infections in Wales, are you able to help with why the Welsh Government didn't implement more frequent testing sooner of patients during a patient's stay in hospital? And is this something Public Health Wales advised or not?
I think the recommendation was from fairly early on to test people who were symptomatic and then when they presented to hospital, and then there was advice to test asymptomatically people who were coming in electively. It did appear from the Welsh Audit Office report that that had not been implemented by colleagues in the health boards. And then there was later advice on routine testing of hospital inpatients, which was initially at day 5 following admission, and then subsequently to every 5 days. And the uptake of that by health boards was variable, and we reviewed that, in fact, in 2022 and found that it was variable across the health boards as to how they had implemented that.
Thank you, Dr. Howe. Thank you, my lady. I'm most grateful for the time.
Thank you, Ms Parsons. Mr Thomas. Mr Thomas is round there.
Oh, thank you.
Good afternoon, Dr. Howe. I represent FEMHO, that's the Federation of Ethnic Minority Healthcare Organisations. In paragraph 546 of your witness statement, you note that data from sources such as passenger locator forms and other UK nations was not integrated into the contact relationship management system and had to be manually inputted. What efforts, if any, were made to integrate these data sources, and what operational impacts did the lack of integration have on the delivery of Test, Trace, Protect programme?
So I think that it was difficult during the pandemic to make much progress with the automated data integration, which was the challenge. And so we had to rely on manual data entry, which was obviously time-consuming. The impact was on the time, and at times us having an incomplete picture of the situation.
At paragraph 547, you state that the epidemiological reports based on the CRM data were used to guide strategies and advice. How regularly were these reports reviewed and adapted to reflect real-time changes in infection patterns or risk among different population groups?
So the situation evolved during the pandemic. I mean, epidemiological reports were given on a daily basis, and then more thorough reports on a twice weekly and later weekly basis.
Paragraph 549, you refer to SAGE's recommendations for essential data fields for test and trace systems. How did Public Health Wales assess its readiness in relation to the recommended data fields, and were there any gaps identified that required urgent remedy?
As stated in the statement, we went through the data fields as required by SAGE, and we were able to show that most of the data was already captured in Wales at that time. There were one or two elements that were not captured.
Gaps.
Sorry?
Gaps. When you say one or two elements, there were one or two gaps.
Gaps. Yes, there were one or two gaps that we then sought to remedy.
How urgently?
I think as soon as we could.
At paragraph 555, you highlight the poor completeness of occupation, place of work, and ethnicity data in the CRM system. Given these gaps, how did they affect Public Health Wales' ability to evaluate adherence to or to assess the equity impacts of Test, Trace and Protect programme, particularly among ethnic minority or low-paid workers?
Yes, this was a particular challenge, and as your question implies, it did mean that we had some gaps in the information. We felt that we had a reasonable overall appreciation. However, as you say, we didn't have this information filled in as much as we would wish, and we fed this back to the local teams because the reason that it was not filled in was because the contact tracers were very focused on speaking to contacts and telling them to isolate, and were not always collecting some of the important metadata that we were relying on. So we fed that back to them, the importance of filling that in.
At paragraph 558, you refer to efforts to improve the recording of ethnicity data in NHS systems. What concrete steps have Public Health Wales and its partners taken since the pandemic to improve the recording and use of ethnicity data, and are these measures now embedded in routine surveillance or emergency planning?
Yeah, so in our IT systems that we're now using, and we're also seeking to procure a new system, a replacement to the Tarian of which we've spoken earlier. In that and our current systems, a number of these fields have been made mandatory, so that staff have to, record a response.
I now want to move on to another theme, which is lessons learned. What lessons were learned from the data reliability issues with postcodes, addresses, ethnicity and international travel in the CRM system, and the lack of integration of certain data sources?
So I think the lesson that isn't necessarily learnt, but is to be learnt, as I said earlier, is that data interoperability is key. We have made some steps in terms of what I said earlier around mandatory fields to try and improve some of the information that we collect, but being able to move it between different systems, I think, will be key in the future.
Let me move on. I want to do these last three questions very swiftly, if I may. What changes would you recommend to improve data accuracy and completeness in future public health programmes and ensure better integration of data in future contact and tracing of healthcare systems, surveillance systems?
So I'm not sure if I'm misunderstanding the question, because I'm not sure that I've got anything to add over what I've said around interoperability and ensuring the data capture in the first instance.
Given the operational challenges caused by the lack of integration that we looked at of certain data sources, passenger locator forms, etc., what improvements would you recommend to ensure better integration?
Again, it's similar, but it needs a review of all the different systems, because it potentially might not be recognised which systems do need to be integrated, but across the board, integration or interoperability more, I think, is the answer to the question.
Okay. Any specific recommendations you would make to improve the consistency and accuracy of ethnicity data recording in the NHS public health systems to ensure more equitable and inclusive pandemic responses in the future?
I'm sorry, I don't have anything to add. I think it's key information because it enables us to understand the impact on different parts of society, and it really should be a priority for the future.
Finally, this. In the light of the challenges faced with aligning data fields with SAGE recommendations, are there any steps that could be taken to ensure that future public health systems are better prepared and more adaptable in terms of data collection and analysis that you can suggest?
Well, as I referenced, we are looking at a refreshed system in Wales, and all these issues are well acknowledged that, for the future.
Dr. Howe, thank you. Milady, sorry for racing through them.
No, don't worry. Thank you very much, Mr. Thomas. I'm very grateful. Dr. Howe, that completes the questions that we have for you. You've spoken about the time during the pandemic very calmly, but that's probably your professional training. It must have been enormously pressurised for you and your colleagues. So thank you very much for all that you did and your colleagues did to try and keep the people of Wales safe. Very grateful to you for that work and, of course, for helping the inquiry.
Thank you.
Very well. I shall turn at 25-2.
All rise.
Good afternoon. My lady, please could Oliver Munn be affirmed?
Could you repeat after me, please?
Yeah.
I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Take a seat.
I hope you were warned that you were last on today, Mr. Munn.
Yes, my lady.
Could you please give the inquiry your full name?
My name is Oliver Munn.
Mr. Munn, quite unique in this inquiry, you provided a one-page witness statement to the inquiry, dated the 30th of April 2025. Can I ask you, first of all, to confirm that the content of that statement is true to the best of your knowledge and belief?
It is.
And in reality, you are, by this statement, confirming that the statement of Jessie Owens, dated the 15th of April 2025, who was the corporate witness for the Cabinet Office, was true to the best of your knowledge as well and belief. And perhaps if we just briefly identify, at page 108, please, the signature and date of the statement of Jessie Owen, please. Thank you. But essentially, you've adopted this statement now as your own, and so for all practical purposes, you are the corporate witness.
That's right.
Thank you. So can we then start with identifying yourself, please? You tell us that you're a former senior civil servant who had the role of Director, Testing and Tracing Delivery in the COVID Task Force within the Cabinet Office from the 28th of April 2020 to the 25th of February 2022.
That's
And I
right.
think it's right that prior to joining the task force in the Cabinet Office, you were in the private sector, is that correct?
That's right.
And so we need to bear in mind that you only arrived 28th of April 2020. Thank you. And you tell us that essentially you were in that role for the 2 years to the February of 2022, but thereafter you were part of the UK Health Security Agency's Director General Health Protection Operations from 2022 to 2024. And can you help us identify, because I think you're back in the private sector now, when in 2024 did you leave UK HSA?
On the 31st of March 2024.
And so can we thank you for, notwithstanding that background, agreeing to speak to the corporate witness statement on behalf of the Cabinet Office. But perhaps before we identify the role of the Cabinet Office, can we just understand then, as a Director of Testing and Tracing Delivery in the COVID Task Force in the Cabinet Office, can you give us an idea what that practically meant day to day when you first joined in April of 2020, please?
Well, in April of 2020, NHS Test and Trace had not been set up. It was still a period where things were moving very quickly. And indeed, I didn't join on the 28th of April with the title Director Testing and Tracing Delivery, because at the time things were so fluid that portfolios would change day to day. And so my first week, I remember I did something on transport and something on test and trace and something on businesses. And it was only really over the course of May that my portfolio became defined as everything relating to testing, tracing and isolation.
And so then taking that date then of around May when you then became the director, for testing and tracing. Can you just give us some idea, bearing in mind we're going to look at the roles of different departments they had in supporting the work of particularly the test trace system. What were you actually doing day to day, just to get an idea practically of the involvement of the Cabinet Office and you in particular?
So the Cabinet Office corporate statement refers to 3 roles that the Cabinet Office played, one of which was a critical friend role. And my lady, I spoke to test and trace colleagues pretty much every day for 2 years, ensured that I was aware of exactly what they were doing, where they were going, fed into their strategy, updated them on the government's broader COVID strategy so that everything test, trace and isolate related fully tied into where the government was and was going on non-pharmaceutical interventions, vaccination, etc. The COVID Task Force also played an important role in relation to collective agreement and the process of ensuring that decisions were properly taken by ministers. And so the task force was the secretariat for the COVID Operations Committee that ministers used throughout the pandemic to make decisions. And in that regard, I and my team would sometimes draft papers for COVID-O to consider on testing, tracing and isolation matters, or at least draft chair's briefs for the chair of COVID-O and the CDL.
Thank you. Well, can we then please turn into the statement 587352 at paragraph 2.5, please, just to make sure we're clear before we get into the detail of the role of the Cabinet Office, please. So it's paragraph 2.5 on page 7 of the statement of Jessie Owen 587352, please. Thank you. Now, paragraph 2.5, you detail that throughout the pandemic, including in the context of work relating to TTI, many decisions rightly continue to be taken within individual departments. Where collective decisions were not required, the role of the Cabinet Office was, as is typical for the centre of government, focused around strategic coordination, ensuring collaboration between the relevant parts of government, assuring progress and providing challenge to help strengthen policy making and ensure alignment with the government's overarching strategic objectives. And then if we move down, please, to paragraph 2.7, you detail that the Cabinet Office also had responsibility for coordinating the government's response to crises, working closely with the lead government departments. And so just pausing there, it's right, I think you identified that the lead government department for test, trace and isolate was the Department of Health and Social Care. Is that correct?
Correct.
And so can you then help when you describe that the Cabinet Office has that lead in respect of crisis, how that operated in practice in respect of test, trace and isolate, please?
The Cabinet Office, through the Civil Contingency Secretariat, that I think you heard about in Module 2, my lady, plays an important role in planning for crises and in the early stages of a crisis in coordinating the central response. But as I think Lord Sedwell in his evidence in Module 2 made clear, the aim is then to hand over to the lead government department as quickly as possible. And so responsibility for testing, tracing and isolation was obviously the responsibility of DHSC. And it was rightly for DHSC to lead the planning and operationalisation of TTI.
Thank you. Can we just highlight another number of paragraphs that perhaps help understand the dynamic that operated between the Cabinet Office and the Department of Health and Social Care? Paragraph 2.18, please, at page 9. You detail that the Cabinet Office was not and would not have been expected to be routinely involved in the detailed TTI work led by the Department of Health and Social Care and its agencies, for example, establishing, maintaining or monitoring infrastructure, laboratory capacity, testing technologies or other associated capabilities, nor would the Cabinet Office be expected to assess overall UK preparedness to develop and scale diagnostics for a given disease. This more detailed preparedness work would fall under the responsibility of the Department of Health and Social Care as a lead government department. DHSC and its executive agencies, notably the UKHSA, which we know came on latterly and was operational from October 2021, would therefore be best placed to summarise and comment on the adequacy of the TTI policies and strategies in place prior to the onset of the COVID-19 pandemic.
I think this paragraph relates specifically to preparedness. And so what it's saying is that the Cabinet Office would not be expected to be routinely involved in detailed TTI work led by DHSC before the pandemic came along. Hence why there are several references to preparedness within the paragraph. Once that the pandemic had come along and that TTI was a big part of the government's response, the Cabinet Office was very close to TTI work being led by the department, obviously not in the lead role, but as I mentioned, we were having daily conversations with them and ensuring that what they were doing was fully coordinated with the rest of the work of government.
Thank you. And then perhaps just to highlight some additional paragraphs, paragraph 2.37, please, at page 14. Thank you. The statement details, as was the case throughout the COVID-19 response, one unique role of the Cabinet Office was its work to consider and provide advice to ministers on the trade-offs of different TTI approaches, whereas the focus of other government departments centred around, for example, the impacts of TTI policies on health for the Department of Health and Social Care, the economy for Her Majesty's Treasury at that time, or specific sector-based impacts for other government departments. The Cabinet's Office role at the centre of government was to look across the board and support decision makers to understand and balance, where possible, the trade-offs of different response options. Is there anything you want to add in respect of that?
No.
Thank you. And then, significantly, you then identify at paragraph 2.38 that the Prime Minister, Mr Johnson, remained close to this work throughout the pandemic, including through regular, often weekly meetings with Baroness Harding as Chair of NHS Test and Trace, and others closely involved in TTI work, including the Health Secretary, the Chief Scientific and Medical Advisors and other officials, which focused on a range of issues from the ambition to roll out a mass population testing programme to community testing and surge testing in specific sectors and geographical areas. And you also detail, in addition, Baroness Harding on occasions provided written updates on the progress of NHS Test and Trace to the Prime Minister and the Cabinet Office. And so pausing there, can you assist us? Because we know that when Baroness Harding was the Chief Executive of NHS Test and Trace, there was a unique reporting structure initially until the December of 2020, where essentially she reported directly to the Prime Minister. And so can you help us understand that structure set against the lead department being the Department of Health and Social Care, please?
Yeah, absolutely. And it's quite right, you mentioned the word unique. I actually don't think it's unique because the Chief Executive of NHS England had exactly the same arrangement, reporting directly into the Prime Minister rather than the Health Secretary. And so actually I think it was quite a parallel arrangement to that with NHSE before its recent abolition. I wasn't involved in the decision to appoint Baroness Harding or to make her report to the Prime Minister rather than the Health Secretary, but I can only speculate that the Prime Minister was trying to make clear that he was very personally invested in this work and that would send a message across Whitehall that Test and Trace was a foremost government priority and that other government departments should do all they could to assist it in its work.
Thank you. And so in correcting me and describing it as a unique reporting restriction, we know that reporting directly to the Prime Minister came to the end in December of 2020. So can you help us understand then why that shifted after December 2020 and then it went back to reporting essentially to the Health Minister in the Department of Health and Social Care?
So that was a decision made by the Cabinet Secretary, and I can't pretend to know exactly what was going through his mind in determining that. But by way of context, I can tell you that the Secretary of State for Health had been very, very closely involved in all of the work of Test and Trace since the very beginning, and that Baroness Harding, who you're hearing from tomorrow, was speaking to the Health Secretary all the time on everything, and that submissions that Test and Trace was preparing were going through the Health Secretary for his approval. So I think, although the formal reporting line may not have changed until December 2020, in practice, the Secretary of State for Health was all over every aspect of NHS Test and Trace's work from the very beginning.
Thank you. Can we then please look together at paragraph 3.2 on page 28, please? Thank you. Now, you detail there under the development of Test and Trace. As explained in section 2, in line with the lead government department model, The Department of Health and Social Care is responsible for public health protection and responding to emerging infectious diseases. At the outbreak of the pandemic, therefore, the Cabinet Office ordinarily had limited involvement in policy and strategy work relating to TTI. Can you assist then? We've already looked together that the Cabinet Office was responsible for coordination across government departments in response to crises, working closely with lead government departments. And this would have included with regard to test, trace and isolate. Would you agree?
Yeah.
Thank you. And then we look at paragraph 3.5, please. It details, in this early stage, the Cabinet Office worked to understand the progress of test and trace work across government in order to update and provide advice to the Prime Minister and to understand where further support from central government may be needed. The Cabinet Office was not, however, closely involved in Public Health England or the Department of Health and Social Care's detailed work in this initial period to test, trace and isolate contacts, nor is the department able to comment on how any existing capacity, infrastructure, policies and capabilities were used to respond to the initial cases of the novel coronavirus. And so can I ask you then, why is the Cabinet Office not able to comment on how existing infrastructure and capacity was utilised in the early stage, especially given its central coordination role in times of crises?
The central coordination role that you describe, led by the Civil Contingency Secretariat, involves assigning actions and being clear on owners and assessing progress across the whole waterfront of the crisis response. But those actions, those owners, sit in line departments, in the line government, in the lead government department for each of those activities, and the Civil Contingency Secretariat is not staffed to man-mark, for want of a better phrase, each of those work streams that are being led by departments. As we might get on to, it became clear in the spring of 2020 that the centre of government needed to grip a wide range of department-led initiatives, and so a COVID task force was created within the Cabinet Office over the spring of 2020, precisely to provide the kind of close involvement that the Cabinet Office had not been resourced to provide in January, February of 2020.
Thank you. Now, that may partially answer the next question, please, Mr Munn. Do you accept that part of the Cabinet Office role in advising the Prime Minister, it would have needed an understanding of what infrastructure actually existed at the outset of the pandemic? So I think you've dealt with spring, but would you agree that it would have been far better if there was that information known about the infrastructure in the January of 2020?
The Cabinet Office would be reliant on the relevant government department to provide it with information on the state of preparedness in its area or the actions that it was taking. And so in those early days before the COVID task force was created, the Civil Contingency Secretariat would have been commissioning the Department of Health and Social Care for updates on the testing and tracing infrastructure that they had in place, how it was expanding, etc. Would have been receiving updates from DHSE, but would not have been in a position to do much more than pass on those updates to the Prime Minister, and certainly wasn't in a position, as was the case later when the COVID task force was established, to have real subject matter experts who knew all about testing, tracing and isolation sitting within the Cabinet Office and who understood, the various nuances and complications of operationalising a TTI system.
Thank you. Well, I'll take you in a moment to a passage in Mr Johnson's statement by reference to the Civil Contingency Secretary you just referenced. But briefly, before doing that, do you accept that the United Kingdom's lack of infrastructure for testing at scale would have been obvious to the Cabinet Office from January 2020 had comprehensive inquiries been made in that early stage?
As we covered a few minutes ago, I joined the Cabinet Office at the end of April 2020, and so it's difficult for me to state with any certainty what the Cabinet Office should or shouldn't have known in January. What I do know is that from the documents I've reviewed in preparing for this meeting, that the Cabinet Office did ask the HSE for various updates in January and February 2020 as to what testing capacity was in place and could be put in place, and received those updates. I can't tell you to what extent they had the resources or the knowledge to really scrutinise the responses they got back.
Thank you. Well, can we then briefly look at a passage in Mr Johnson's witness statement that he's provided, please, which is INQ 587378. It's page 9, para 22. Thank you. We can see that he details in this statement, I remember I was told that we had an excellent system for testing and tracing contacts, although I cannot now recall who said this. I think I was told it many times by many people. And then it goes on effectively. As an example of the document that gave me this reassuring message about our preparedness, on the 28th of February, the Director of the Civil Contingencies Secretariat sent me a briefing note prepared in consultation with the CMO and the GCSA on the UK's preparedness. The note said our preparations are well underway and we continue to be ready to deal with any more if the outbreak escalates. Our NHS has tried and tested systems to quickly identify and isolate those who may have COVID-19. And thank you. Can you assist? Why did the Director of the Civil Contingencies Secretariat send Mr Johnson this reassuring message about the state of preparedness rather than inform him that there was in fact a lack of infrastructure and capability? Can you assist with that, please?
I can assist by providing context. As I've mentioned, I was not an employee of the Cabinet Office at the time, nor even a civil servant, and I have never worked in the Civil Contingency Secretariat, so my knowledge of their processes is second-hand, but I can only assume that the Director of the Civil Contingency Secretariat had received from DHSC a reassuring update endorsed, as is mentioned by the CMO and the Government Chief Scientific Advisor, and had passed that on to the Prime Minister. I'm afraid there's not much more I can add.
Thank you. And perhaps then if we can go back into the witness statement, please, at paragraph 1.8. So it's the 587352, page 2, paragraph 1.8. We can see that, in fact, the position that is now detailed is at the outset of the pandemic, the UK had very limited capability and infrastructure to test for cases of the novel coronavirus and trace their contacts. Setting up a test and trace system on the scale and at the speed demanded by the virus posed an unprecedented challenge. The UK government worked to meet the challenge in collaboration with a wider public sector, including industry, academia, local government and others. And so identifying that unprecedented challenge, when did it become clear to the Cabinet Office that there was very limited capability and infrastructure? Can you assist?
All I can tell you is that when I arrived on 28th of April, I think that was the feeling within the Cabinet Office. I suppose what you're asking is some point between the note to the Prime Minister at the end of February, where the message from CCS was there's infrastructure in place, and my arrival at the end of April, the message changed. But I'm afraid I can't tell you within that 2-month window exactly when that feeling changed. And obviously the Cabinet Office is a big organisation and different people would have had different views at different times.
No, thank you. But would you agree with the principle that the role of the Cabinet Office should have been to advise the Prime Minister of this lack of infrastructure and capability as early as possible?
Absolutely.
But you can only really speak to that plainly had been identified when you came along near to the end of April.
Correct.
Thank you. Can we then please move forward again to paragraph 3.8 at page 29, please? And perhaps before doing that, we'll start at 3.7, please. The statement details about mid-March 2010, at the time the World Health Organization was encouraging countries to test. Concern was being raised within number 10 about the UK's ability to scale testing to the levels required to respond to COVID-19, particularly in relation to limitations in PHE's capacity for operational delivery of testing and contact tracing on a large scale. And then if we move then to 3.8, you detail that on the 14th of March, CDL, is that the Chancellor for the Duchy of Lancaster?
That's right. Michael Gove at the time.
Thank you. Obviously, as member of the Cabinet, chaired a meeting exploring ways the Cabinet Office could help the Department of Health and Social Care to increase testing capacity. And can I ask you, do you accept that there was no attempt by the Cabinet Office to have a high-level meeting with the Department of Health and Social Care on the subject of test and trace specifically, to understand the UK's readiness in detail until this meeting of the 14th of March of 2020?
Whilst I'm not aware of any other attempts, I cannot categorically state that there were none.
Okay. And can you assist then, if the Cabinet Office did not undertake sufficient detailed work to understand the progress of test and trace until March, but does it look more like that the Cabinet Office was accepting the assurances at face value from the Department of Health and Social Care without examining or scrutinising capability and infrastructure?
The processes of the Civil Contingency Secretariat, as I mentioned, are not processes I'm familiar with. They obviously go out to departments asking them for their plans and their preparedness, and they receive them. I imagine that they do more than just, passing them on to the Prime Minister and saying, we've received this and here it is. But I'm afraid I don't know the level of scrutiny that they apply or the extent to which they dive into the responses they receive from departments.
Thank you. Can I then please briefly ask you about some evidence that we're going to hear from on Friday from Professor Pillay, and it's one of the documents in the pack. It's INQ 475152. That's 475152, and it's page 4, paragraph 15, please. And this is on capability. Thank you. We can see detail there that Professor Pillay details there remain considerable expertise through local directors of public health and outbreak control teams. Despite this, the immediate COVID response involved very significant investment in a series of outsourced functions rather than using such resource to rebuild existing infrastructure. And similarly, the inquiry has a statement from Lord Bethell that similarly comments upon the preference to use directors of public health's knowledge. And so can I ask you, do you agree that the UK's lack of sufficient localised infrastructure for test and trace hampered its ability to deliver a test and trace programme despite directors of public health expertise and local teams?
Let me say that directors of public health have a huge amount of expertise and often are extremely accomplished and talented people. They lead public health teams within local authorities that have faced consistent resourcing and budgetary challenges. It is not the case in England today, and it certainly wasn't in 2020, that we have a well-resourced local public health layer that can be deployed at short notice to do all sorts of extremely ambitious things. There are extremely talented people in public health departments in local authorities across the country, but they are operating on very limited budgets. They often have considerably smaller headcounts than they had historically. And so, unlike some other countries where contact tracing in particular was sent to a subnational level, and I'm thinking particularly of federal countries like Germany or the US, which had well-resourced, high-budget public health departments at a regional level, England does not have that. It has 152 public health teams at local authority level, some of which cover really very small areas, all of which face massive budgetary challenges in the context of local authority finances. And so, whilst there are some exceptionally talented and hardworking people working for Director of Public Health and as Director of Public Health, they are not a well-resourced function that can easily be activated to deliver huge, very ambitious contact tracing as was required.
But can you assist, considering the United Kingdom Civil Contingencies Act framework, which emphasises the role of local responders as the building block to response, did the Cabinet Office liaise across departments to identify and build up the localised infrastructure early on in the pandemic?
When NHS Test and Trace was launched on the 28th of May, it was a very national operation and fairly quickly transitioned into a mix of national and local. And indeed, by August 2020, local tracing partnerships were announced, I believe, on the 10th of August 2020, and the Cabinet Office was certainly supportive of that move to better involve Directors of Public Health and local public health expertise to ensure that contact tracing was more effective and made better use of local knowledge.
Thank you. But obviously that seems slightly later on the chronology. I wondered if you could assist before we get to what was announced in the May, whether you're able to assist from the April when you were in sort of arriving in the Cabinet Office. Was there consideration being given about this existing local resource with the expertise that existed in Directors of Public Health?
I think there was knowledge in the Cabinet Office that Directors of Public Health were in place across the country and often brought tremendous talent, energy and enthusiasm to their roles. What DHSC was tasked with assembling over the course of May 2020, before its announcement on the 28th of May, was a large-scale contact tracing operation that could handle the many thousands, tens of thousands of tests, of cases a day that were forecast. And so they put their focus on building a large, scalable, central operation at first, before then transitioning fairly quickly in the following months to a mix of national and local to ensure that they were making best use of the expertise that was held at local level.
Thank you. And then can I ask, with referencing obviously the large-scale testing and therefore the large-scale central contact tracing, was any thought given about the fact that this is outsourcing to companies with no experience or relevant expertise or local knowledge, in terms of whether that was the best way to go for this centralised contact tracing rather than utilising the local contact tracing?
The first thing to say from a Cabinet Office perspective is that that was a decision for the lead government department, the Department of Health and Social Care. And so the Cabinet Office would not have had a direct role in that. But I would add, by way of context, we were looking at tens of thousands of contact tracers that needed onboarding, and local public health teams who already have a large number of existing and ongoing responsibilities did not have tens of thousands of people sitting around waiting to be to have new responsibilities given to them.
Thank you. Can we then please just look on the chronology? I appreciate we're just picking issues and themes out of the full chronology context that your witness statement provides, but can we please look at paragraph 3.22, where you detail page 39, para 322. You detail there the announcement of the 2nd of April 2020, when Mr Hancock, the Health Secretary, announced the 100,000 testing target across the UK by the end of the month. And can you assist, did the Cabinet Office play any role in the identification of the need to increase testing to the 100,000?
Well, later in that paragraph, it says Dominic Cummings notes that he and the Prime Minister had told the Health Secretary to aim for 100,000 tests a day. So from that, I conclude that the Cabinet Office, or number 10, as part of the Cabinet Office, was very supportive of a stretching testing target.
And so can I ask, with obviously identifying that Mr Cummings and Mr Johnson have been involved in that, do you accept that the Cabinet Office was under a duty to clearly advise that the target was wholly unrealistic rather than simply encouraging rapid expansion of testing capacity?
It would have been for DHSC to judge whether it was realistic or not. The role of the Cabinet Office, and I think the role of the Prime Minister, as he'd have seen it, would be to challenge departments to aim high. And that's what he did with that 100,000 target. And to the point that it was wildly unrealistic, it was met, which suggests that it was not wildly unrealistic.
Thank you. Now, I'm going to move on now to the creation and establishment of NHS Test and Trace. Can we briefly look, please, at the terms of reference, which is INQ 198082. 198082. Thank you. We can see there the Test, Track and Trace Ministerial Task Force terms of reference. And I think at this point we can see the membership included Dido Harding as the chair. And if we move through, we can see that as required, please, a little further down, we only have as required that number 10 will be involved. And then over the page, I think it identifies, as what you've already told, we can keep moving down, that the Cabinet Office had the secretariat role of those meetings. And so without a standing member in the task force, can you assist us to why the Cabinet Office was only the secretariat on those meetings, please?
I think it's important to give some context on this task force. It was announced on the 7th of May, and by the 28th of May had been superseded by the creation of Test and Trace, so it existed for no more than 3 weeks. And I've asked the Cabinet Office, which, as you say here, was the Secretariat, to look through records, and they have confirmed that they have no evidence that this task force ever met in its form. So I think this task force is a bit of an irrelevance, if I'm honest. Now, it's true that these stakeholders remained involved, but the notion of the task force, as described in these terms of reference, I think was quickly overtaken by events.
Thank you. Well, then, can we look at an email that I think, looking from the appointment of Baroness Harding on the 7th of May, at an email of the 18th of May, just to try and understand something that you were involved in, and it's INQ 195932, please. That's INQ 195932. Thank you. And so this is an email of the 18th of May 2020, so almost just over a week before the announcement of the NHS Test and Trace strategy, which was then going to be implemented on the 28th of May. And we can see that you're one of the recipients of this email. And essentially, we just move through the policy. If we look at the punchline is that most of the big design questions remain unresolved, with some pretty fundamental differences of view as to what this programme is trying to achieve and by when. And then we can obviously see reference to the app, and it won't involve the app. So this is the 18th of May suggesting that the app wouldn't be involved. It won't be very good, but that's Ida Harding, thinks she has agreed with Chris and Patrick that it will be good enough to begin with, if coupled with the JBC being able to implement effective measures. And again, if we go over the page, the time doesn't allow to go through the detail of this, but if we go over the page, please, we see questions outstanding, and they include relating to strategy, speed and scale, fundamental questions about isolation, then over the page, asymptomatic contacts and testing, enforcement, and again, in respect to the app on page 3, questions about what was the hurdle to the app to make comfortable enough to launch it, and again, over the page, questions around sort of further issues of testing and capacity. And so can you help us? We know that this is the 18th of May, with some fairly fundamental concerns being expressed about the strategy of test, trace and isolate. Can you help us understand this in the context of then what happened in the announcement on the 27th of May? Was test, trace and isolate at this stage in a very poor state?
Let me first say that I think you were asking earlier about the role of the Cabinet Office vis-à-vis DHSC. This is a wonderful example of the role of the Cabinet Office versus DHSC, which is to say the Cabinet Office asking difficult questions, including big picture difficult questions, and tasking them to DHSC. And you'll see in this email, Tom Shinner writes, "I've agreed with Dido that if we give her 7 days, they'll come back with what they think the answers are," which is exactly the role that the Cabinet Office should and did play. It's clear from this email on the 18th of May that Tom Shinner, as well as others who he references, and I'm among them, still had some concerns over whether Test and Trace was going to be ready to launch promptly. But to give full credit to Baroness Harding and her team, they engaged with these questions promptly and came back with answers, and there were a series of discussions over the following week which got us into a place collectively where we were happy to go ahead with the launch of the Test and Trace service on the 28th of May, just 10 days later.
Thank you. Now, there's 2 references to the app, and essentially this seems to be identifying that it was not going to be ready. But can you assist them? When the announcement was made of NHS Test and Trace and the public announcement on the 27th of May, it indicated that to complement the rollout, there would be the NHS COVID-19 app that was predicted to follow in a couple of weeks or in the coming weeks. And we know, in fact, that it wasn't rolled out until the 24th of September 2020, so 4 months later. This email seems to suggest that the significant issues with the app were still not dealt with. And can you help as to why then it was expressly referenced as being almost imminent on the 27th of May?
I think by the 27th of May, apps had already been rolled out in various European countries, and the Prime Minister and the Health Secretary felt the need to say something about an app. But you're right, on the 27th of May, the app was not ready to go, and it would, as we know, it would take several more months for it to be ready to go. But I think ministers wanted to signal that that was a desired direction of travel, and that we weren't ignoring what others were doing in other comparative countries, and that we wish to make use of all the technology available to ensure an effective testing, tracing and isolation system.
And can I ask you, was there not an issue, though, of public trust then in suggesting that the app was about to be rolled out in the next couple of weeks? Would it not have been better to be more open about the stage that the COVID-19 app was at, rather than in the rollout of NHS Test and Trace almost heralding that the app would be with us in a couple of weeks?
It's a good question, and a question that comms professionals within Number 10 were doubtless considered. I mean, my memory is not good enough to know whether on the 27th of May we were clear how far away the app was. I think we all thought the app was going to come sooner than it did. There had been a successful trial on the Isle of Wight in April or May 2020. And so I think that, if you'd have asked the average person within the Cabinet Office or Number 10 when's the app going to come, they wouldn't have said as late as the 24th of September. But I would say the Cabinet Office was broadly supportive of the principle of getting the app right before rolling it out. And you will see emails from Tom Shinner, from Ben Warner and others saying there was a very real risk of going live with an app that wasn't ready, that would lose public confidence, and you only really got one opportunity to launch it and drive take-up, and that if an app was rolled out prematurely that was unstable or not functional, that would destroy public confidence in the app. And just one thing I'll say is that the effectiveness of a Bluetooth app is proportional to the square of the number of users. So if you double the number of users, you have an app that's 4 times more effective. Hence, it's incredibly important that you get high take-up. And that's why there was a real desire from the centre to ensure that the app was not launched until it was ready to go.
Thank you. Can I briefly then ask you about just 2 paragraphs? There are others where Baroness Harding, in a witness statement, comments upon the role of the Cabinet Office. But please, could we display INQ 587322 at page 21, please? That's 587322. And it's paragraph 5.10. We're going to hear from Baroness Harding tomorrow, but because the Cabinet Office are referenced, I wonder if you can assist at all. We can see at 5.10 its detail. For example, NHS Test and Trace faced various difficulties in obtaining HMT and Cabinet Office approval for Lighthouse Laboratories in the summer of 2020. And this meant the approval process for expansion of the Lighthouse network took far longer than it should have in the circumstances. Had NHS Test and Trace had greater delegated procurement authority during this time, this would likely have reduced the capacity issues we experienced in the autumn. And so can you assist the criticism of the delay then in the later rollout of the Lighthouse Laboratories seems to be referencing difficulties in the Cabinet Office approval. Can you give us some context to whether that's accurate as to the assessment made by Baroness Harding, please?
Of course. In Module 2, Lord Sedwell, the former Cabinet Secretary, gave evidence to the inquiry, and I think he very aptly described the dual roles of the Cabinet Office. The first is to coordinate cross-government action on the Prime Minister's top priorities, such as COVID, and the second is to act as a shared service provider across government on things like digital, legal, commercial, HR, etc. And I think what you see here is the second of those. So I was in the COVID task force, which was very much the first of those, but there is a government commercial function as part of the Cabinet Office that is charged with ensuring that departments follow commercial best practices and commercial rules in order to deliver the best possible value for money to the taxpayer. And I think what Baroness Harding is referring to here is that Test and Trace had to get approval from the government commercial function and from the minister, who was Lord Agnew, for various spends, and at times that process took longer than they'd have liked. What I will say is that the government commercial function moved very quickly compared to its usual pace, very much took on board the exceptional circumstances in which we were operating, and was broadly very expeditious in getting approvals to Test and Trace. But I think on these particular occasions, there are some emails that suggest that Lord Agnew, as the minister, had some concerns and some questions that he wanted answering before he was willing to approve the sign-off. My lady, I believe you've heard from Lord Agnew in previous module, and you'll know that he had strong opinions on these topics.
Thank you. And then briefly, can I take you to the next paragraph of Baroness Harding's statement, please? 5.11. It's detailed, these challenges were further exacerbated by the inherently unpredictable nature of the pandemic. In December 2020, NHS Test and Trace was encouraged to move towards a more business-as-usual environment and increase focus on value for money across the organisation, including in relation to procurement. Shortly afterwards, a new variant of the virus emerged, which led to the standing up of new use cases, such as the testing of hauliers at the border and of secondary school staff and pupils at very short notice, and the need for a third lockdown. This meant that simultaneously, NHS Test and Trace was being challenged by the Prime Minister to scale faster and the Cabinet Office to slow down. Can you assist you identify, in this time period in particular, the Cabinet Office is seeking to slow down matters?
I think, per my previous answer, this is a reference to commercial approvals, and I think the exhibits that are attached to that relate to some emails that Lord Agnew sent laying out his concerns about approving certain spend.
Thank you. Can we then briefly, just to make sure there's absolute clarity about the ultimate responsibility for the development of testing, can we look at 3.47, please, in the 587352 statement to which you're speaking at page 47? That's paragraph 3.47. Thank you. Sorry, INQ 587352. Sorry, we're back into Jessie Owen's statement now, please. 587352 at page 47, paragraph 3.47. Thank you. If we can move into page 47, please. Thank you. So, just so there's absolute clarity as to responsibilities, we can see at paragraph 3.47, you detail that under the leadership of the Executive Chair, NHS Test and Trace had the Prime Minister's full authority to deliver. Ministerial accountability to Parliament remained with the Health Secretary. Considerable freedoms and independence were afforded to NHS Test and Trace to expedite the delivery of testing and tracing. Baroness Harding was given permission to draw upon resources and expertise across government to bring in external experts as required, and all government departments were instructed by the Cabinet Secretary to provide any necessary support that NHS Test and Trace requested. And then the next paragraph, please. 3.48. At the same time, it was important for the Cabinet Office to maintain a proportionate level of central oversight of work undertaken by NHS Test and Trace, given its centrality both to understanding the virus and to the government's overarching strategy for managing the pandemic and easing restrictions. And so can we just have complete understanding of who ultimately was responsible for the development of an effective large-scale mass testing tracing system?
Baroness Harding.
Baroness Harding from NHS Test and Trace. And can you assist then in terms of that sitting within the Department of Health and Social Care as the lead government department? How did that work?
Baroness Harding and all of the officials working with NHS Test and Trace were members of the Department of Health and Social Care. Indeed, they worked out of the DHSC building. They had DHSC email addresses. and in practice, they sent submissions to the Health Secretary and Health Ministers before making important decisions. But I think Baroness Harding will be able to describe the inner workings of Test and Trace to you better than I can.
Thank you. Now, can I briefly touch upon Operation Moonshot, which was then the Prime Minister who made the announcement on the 9th of September 2020 about his desire for Operation Moonshot. It's your paragraph 3.91. I don't think we need to turn to it. But can you assist then as to why the Prime Minister was getting involved again in testing strategy, which ultimately has had quite a number of people criticise the Operation Moonshot philosophy. And I think ultimately, from that announcement on the 9th of September, I think the tests that were identified that would have been part of Operation Moonshot effectively were used as part of the community testing programme that came in November of 2020. But do you have any observations from the Cabinet Office's perspective of the Prime Minister essentially making that Operation Moonshot announcement?
I think by way of context, it's worth remembering that until vaccines came along very late in 2020, testing, tracing and isolation was one of the largest tools at the government's disposal, and it's absolutely natural and right that the Prime Minister should take a personal interest in it. I think the PM was very excited by the possibilities that large-scale testing using lateral flow devices offered. These were a technology that had been around for years but was only really proven to work for COVID at scale from autumn 2020 onwards. And he saw in that a huge tool in the government's arsenal for combating COVID, particularly before vaccines arrived. So I think it's no surprise that he was keen to push NHS Test and Trace to move fast on the rollout of lateral flow tests.
Thank you. Can we then please move to the topic of financial support briefly, please? And can we move to paragraph 5.18 at page 85? That's INQ 56. Thank you. You detail at paragraph 5.18, by mid-September 2020, with infections rising and evidence suggesting only a very low percentage, circa 20% of those with COVID-19 symptoms in England fully complied with self-isolation guidelines, and that rates of self-isolation by other household members and contacts were likely to be even lower, the COVID task force prepared advice for the Prime Minister recommending a carrot and stick approach to increasing compliance. We obviously know that the figure that was then arrived at subsequently was £500. Can you assist? Did the Cabinet Office have a view on whether £500 was an adequate amount?
I think there's some important context to provide here. Ministers, including the Prime Minister, had been arguing for some time that they were keen to increase support to self-isolating people, both financial and non-financial support. But there had been a range of views across ministers on this topic, I think it's fair to say. And it took some months of conversations at official level, at political level, to get alignment across government on what that would look like, and eventually a package that was acceptable to the Chancellor, the Health Secretary and the Prime Minister emerged, and that was the package that is described in paragraph 5.18.
Thank you. And are you able to assist how the needs of those from ethnic minority backgrounds were considered in decision-making in respect to the provision of financial support for isolation?
Absolutely. Test and Trace, by the summer of 2020, was doing a lot of work to understand the barriers to self-isolation among groups of all types, with polling data, with follow-up calls to people self-isolating, asking them whether they'd fully complied, etc. And although NHS Test and Trace is best placed to answer this question, from my personal recollection, I know that they really went into the data on what was keeping people from self-isolating, people of all ethnicities, people in different professions, different income levels, and so they built up a data picture that was able to move ministers towards alignment.
Thank you. And then can we pick up then, perhaps on that theme, on inequalities and disproportionately impacted groups? Can we move, please, to paragraph 6.5 at page 93, where you detail the Cabinet Office's involvement in work to address inequalities in relation to TTI began early in the pandemic, prior to the establishment of the COVID-19 task force and NHS Test and Trace. And so can you assist? The Cabinet Office provided guidance to the Department of Health and Social Care on the public sector PHE, as well as equalities insights regarding the potential impacts of TTI policies. How are the needs and concerns of those from ethnic minority backgrounds, including healthcare workers, factored into this?
The Cabinet Office was home to the Government Equalities Office that eventually merged with some other teams to become the Equalities Hub. And I'd also add that on the establishment of the COVID Task Force, a team was established within that task force focused on disproportionately impacted groups. So there was a real focus at the Cabinet Office that then saw the appointment of Emma Meehan as the senior responsible owner for disproportionately impacted groups. I know that you heard from him, my lady, recently. So the Cabinet Office was very keen to share with the HSC and with NHS Test and Trace the expertise that the department had on equalities questions, and to ensure that NHS Test and Trace took full advantage of the knowledge that was at the central government.
Thank you. Now, if we just move forward, please, to paragraph 615 on page 98, please. And throughout 615 through to 620, you refer to the recommendations in the quarterly reports on inequalities, including to improve participation in the TTI system. Can you assist? Were the recommendations from those reports implemented?
So I can't speak to those exact reports. What I do know, though, is that following the pandemic, the government launched an Inclusive Britain Action Plan with 74 actions that I think incorporated many of these actions that had come from the quarterly reports during the pandemic. That action plan the government has been providing periodic updates against. The most recent of those updates was in May 2024, when it was reported that 62 of the 74 actions had been completed. I don't have an update since May 2024, but I can tell you that at that date, the vast majority of the actions in the Inclusive Britain Action Plan were complete.
Thank you. And then can I move then to lessons learned and recommendations for the future? The Cabinet Office has provided 7 pages looking at lessons learning and recommendations. Can we please briefly look at paragraph 7.6, please, at page 103? Thank you. It details there a number of recommendations were made by the COVID-19 task force strand of the project. And I think this is a project that following the spring of 2022. One recommendation was to ensure equalities considerations were central to decision-making from the start, and to identify those who may be disproportionately impacted as early as possible, e.g. multi-generational household, whilst recognising that disproportionately impacted groups will not always be the same cohort of people. Another recommendation was to create and maintain an overview of all pressures on local authorities and key delivery agencies related to policies and decisions in question to ensure effective allocation of resources. Are you able to assist as to what specific action the Cabinet Office has taken since the review to implement this recommendation and to ensure that equity is embedded in its decision-making processes?
Yes, I have 3 updates. Firstly, the National Security Risk Assessment methodology now includes a specific impact category on vulnerable people, with the Cabinet Office having issued new guidance to departments in October 2024 to improve consideration of the disproportionate impacts that risks may have on different groups across a full spectrum of vulnerability. Second, supported by the ONS, the National Situation Centre has created a risk vulnerability tool to estimate the number of people who are vulnerable to the negative impacts of national security risk assessment risks. It'll be made available across government, including to the devolved administrations. And thirdly, lessons management best practice guidance published last year on gov.uk now advocates for a participatory approach to emergency management which considers the impacts of emergencies on individuals and builds community resilience.
Thank you. And then finally, can I take you back to 7.4, please, which deals with data and analyses at page 102. Obviously, data analyses was one thematic area reviewed as part of the Innovation and Lessons Learned project. It goes on to detail that the report acknowledged that more interoperability between digital systems across government would improve the ability of the state to rapidly introduce new digital services. The inquiry's heard quite a lot of evidence about issues of data blockages, and with a number of criticisms levied us against how data was managed within the Department of Health and Social Care and how that operated across departments. Are you able to provide any update of any work that's been done to improve data sharing or interoperability?
I'm afraid I'm not, but I do know that this remains an area that the government is focused on, and that recent public statements have focused on the need to share data better across government, particularly in an age where AI and other tools are emerging.
Thank you, Mr. Munn. Those are my questions, my lady. There are no core participant questions that have been permitted.
Thank you very much indeed, Mr. Munn, and thank you particularly. I mean, having left the civil service to return to the private sector to volunteer, I assume it was volunteering rather than anything else, to come along and help the inquiry. I'm really grateful to you.
Very welcome.
Very well, it is 10 o'clock tomorrow.
Thank you, my lady.
All rise.